Hi, we are here today with Dr. Elizabeth. She is a chiropractor at Mountain Spring Chiropractic in Fishersville, and we are going to talk to her today a little bit about pregnancy and chiropractic care during the prenatal and postpartum periods. So if you want to introduce.
Hi, thanks for coming. This is a great opportunity, and we really enjoy our pregnant patients and working with them. So I'm looking forward to these questions.
Yeah.
Wonderful. All right. So just to start off, we're going to ask, is this safe, having adjustments during your pregnancy?
It's very safe. I've done our literature review. There's not a whole lot of literature on PubMed, but it's very safe. There's no chemicals, there's no medications. So very safe. I was adjusted all through and during delivery. So I have that side of it too.
That's wonderful.
What was it like being adjusted during delivery? That's fascinating to me.
I trained my office manager. So, and my midwife allowed it, and I guess the doctor behind her either didn't know it or allowed it, and we were in the hospital. But it seemed to help a little.
Yeah.
It's labor. It's definitely labor.
Sure.
And my son was sunny side up, which apparently nobody knew until the end.
Yeah.
So it was quite a labor, and the delivery nurse, not the midwife, but the nurse said she had never seen one not go to C-section in all her 30 years, whatever. It was a lot of years. So I just thought, go chiropractic.
We'll take it. Yeah. So when people come to you during pregnancy, what are some of the most common reasons why people would come to you?
Usually if there's a symptom, it's low back pain. Sometimes it's actually sciatica.
Okay.
A lot of times it's not true sciatica. It's a pseudo sciatica, but it's usually back pain and leg pain. Sometimes they just come because their caregiver says they should come and be checked to make sure everything's moving right and getting ready for the big day.
When would you suggest the soonest that somebody comes to see you?
Even before they're pregnant. As Leah knows, we believe in regular care all the way through. Our youngest, we'll probably get to that. Our youngest patient was a week old. Our oldest have been in their 90s. So, the structure is so important. And as we say, I'm an adoptive Virginian. So in the maybe Virginia way of saying there ain't no drug gonna move no bone. So if something's crooked, we want to get it straight. So as far as we've had people come, mothers come the day before they were due, which I actually deliberate, should I accept that or not? But it might help as soon as they know, really. I've been thinking on that question, but as soon as they know. So we can keep things going right, so we can keep the brain connected through the spinal cord to everything, the baby and the mom. So as soon as they know.
Yeah. And also helping keep the pelvis aligned can also, not only the structural part, give room for the baby to get in the best position, but it can also allow all the ligaments and the muscles and everything to be loose enough to let the womb have the space it needs for the baby.
That's what I've learned and in the studying I've done.
Yeah. How many weeks do you usually see somebody in pregnancy? So how long? I guess if they started at their beginning of their pregnancy, you would see them to the end?
We see them all the way through. There's different intervals depending on what's going on, what their goals are. At about 34, 35 weeks, we recommend every week.
Okay.
They're always welcome. Gal recent, well, not that recent, her little boy's about 3, but we saw her on a Sunday. I'm willing to do that. That's my gift to the mother. And she sent me a picture the next day holding the baby.
Oh, how sweet.
Yeah. So it depends on the goals. You know, if they're asymptomatic, we start with, and I'll get into this now if that's okay.
Mhm.
We do the exam, which is abbreviated. We're not doing stem to stern, but we do the exam. I like to and do something that day. Typically, maybe with regular patients, depending on their history, we don't adjust the first day. But with the moms, we do something, and then I like to have them back within a week or so to check. Then, if that's okay, we'll go 2 to 3 weeks, you know, something like that. If there's any issues, it's weekly or more. But when we hit that last month, it's weekly.
Mhm. Yeah. Because so along those lines, how long would a typical adjustment hold? And how do you preserve that as long as you can, I guess, after you get adjusted?
I've been thinking on that since I've read your questions, but it depends so much on the structure. And when we are working with a pregnant mom, unless she's had care before, we don't know what their structure's like.
Mm-hmm.
We don't know if it's straight, if there's lateral curve, if there's disc herniations. We just don't know a lot. So it's a lot of how did you do since we saw you last, which we ask everybody. And then that mini exam that I do on everybody just to see. And we discuss it along, especially that first visit. But as the baby grows, it's going to tug and it's not going to hold as much. Now, if they're athletic, it'll hold better. There's a certain amount of genetics, not a lot, but a little bit. How are their feet? You know, if their feet are really bad, it's not going to hold as much. And we do have a system where we can get custom orthotics through the pregnancy that change depending on the trimester. But that's why it's called practice.
Yes.
Like I really don't know. I'm thinking something just popped up. A good response is, what do they do during their day?
Yes.
You know, if they have 5 other kids and 3 of them are toddlers, they're picking them up, and we have those. Or are they working as a waitress on their feet all day? So it depends on a lot of the ADLs during their day. So we just work with them as with any of our patients. They're in control of when they come. I give my best recommendation, but the moms come. They like to come. It doesn't hurt. They feel good. One mom said recently that she considers this her 15-minute rest period. It doesn't even take 15, but
yeah, it's her me time.
It was, but she felt so relaxed. So that was good.
That's a great option for it's self-care. You're caring for your body, which you have to live in for the rest of your life. And then the longevity of maybe your child's body also having some work.
That's what exactly I thought I just had. Yeah. Such a good thing.
So is there a particular kind of technique that you would use for pregnant people?
Great question. I use the same umbrella techniques that I use on any patient. So let's go over that. There's the traditional where you lock the joint out and go a little past that and you get that pop.
That's the crack that we always think about.
It's the joint isn't cracking. We do say we're moving some bones or we're restoring motion to a stuck joint. So what happens is there's nitrogen gas in the synovial fluid. And when you suddenly gap that joint, it turns into a gas. It's a sonic boom is what it is. So, you know, I take care of my own fingers and adjust those, but that's the main technique known, but it's not the main technique I use even in the office across the board. And a lot of the reason for that is some people are scared of it. Some people have hardware. They have hardware in their spine and we can't. Or we can't near there or whatever. Or a lot of people are afraid of chiropractic. You give them credit for coming, talking to us. But when they see how small I am, they're like, oh, she can't hurt me too bad. So we've had a lot of the guys say that or think that, and they've shared it with us. So there's the traditional. Then there is table assisted. Is this showing in the thing pretty well? This is, I call this one my Lamborghini. We have a Cadillac in the other room. We have a Buick. We have a couple other ones. There's a bicycle over there. But all of these do things, and I'll show you this. Okay, so we can move that. That would work the low back, and that's real easy. You can see how easy that is. Okay, it also scrolls out. So it does that, and then we do a little more. Now I use this on pretty much everybody, except the little kids. Then there is the, it's going to make some noise, folks. The Dr. Thompson, also known as the drops. Okay, so watch this. This cocks. Now no one's on here, so I'm going to let the pressure out. And this would be pelvis area in most people. So if the sacroiliac is stuck, I put my hand here and I would do that. Now I don't use this too much on pregnant women. I have some, but it's loud, right? And I know the baby's hearing a lot, respiratory, GI, talking, but that's sudden. The other table is even louder. Okay. So I don't like to use this until the last trimester, even further along. So there's regular, there's table assisted, and then there's instrument. And this is the thing I use the most. It's an electric instrument. Here's just one of the tips. This would be a neck tip. It's got the two. We would straddle the neck, but it punches real fast. Really comfortable. And Leah has said that. Real comfortable, and that's 12 beats per second. Now a little toggle here. We're going to go to 6, and you hear the difference. I never use that. I never even use the single. I just use this. 12 beats per second is the frequency the brain likes. So it's kind of like a soprano breaking glass with her voice. So it's very comfortable. Probably also works on reflex because it's not going to move any bone either. Really, it's going to put motion in that joint. But that's why we study, I'll get into a little bit of our studies. We study anatomy. We're in gross anatomy lab 6 days a week our first semester. So you've got the skeleton upside down and how far the facets are and what angle. So we put this on the area we need to work on at the right angle and do that. We also can vary the pressure. I never use that on pregnant women, and we can vary it here. So we got regular, we got table assisted, and we have instrument. Oh, and then we have another thing, which I do sometimes use. We have wedges or blocks, and this would go under the pelvis. So it's kind of table assisted too. Very comfortable. I use that on everybody if it's the right thing to use. I don't use it a lot, but we will figure it out. Yeah, that's the thing.
Very tailored to each person's
very tailored
situation.
Then, I forgot one other thing. We had a young lady come, I think she was due in a week. It was the first time she had come. She was afraid to lie down. I said, oh, it'll be okay. Should I show this now? Sure. Okay. Yeah. These two were in tandem, and you heard that release. When someone lies down on it, a pregnant woman, it depresses that. It's very comfortable. Well, she wasn't comfortable, and the other room has a little different release. You actually set the angle and the depth. Well, what we did for her, and we do this on everybody that needs it, is we put the ball here, I raised it to her height. She just draped over it, and she had sciatica. And I thought, okay, I was praying. I want to help her, but I like to do on the table work first. Yeah. But we did this, and then I didn't see her, ran into her at a community gathering. She was holding her baby, and she said it helped. So this is what we call weight bearing or gravity assisted. Some say it's more accurate. Again, we use what works.
Yes.
And this works because of the weight bearing, and also you're on an unsteady surface. So the brain is like, what's going on?
Yeah.
Paying a lot of attention. So when I come in with this, it's ready. It's like primed and ready to go.
So back pain, sciatica, symphysis pubis dysfunction are huge things that happen to a lot of women during their pregnancy. And what are some specific things you can do to help that? Can you help that?
Yes, we can. I haven't done a lot of work on that during the pregnancy. It seems to be after.
Okay.
And then we have a lot of people, all ages, that get that work. But certainly we can and have. Typically, I would have them on their back and palpate to see which side is high. Or, pardon me. We can't pump up the low side. The low side might be the side that's off. So we find the high side, whether it's superior or anterior, whatever it is, and we tap it into the right direction. Then I have them squeeze their knees together, and that often will cause that release in audible, and it's instant relief. It's fabulous because I've experienced that myself. The ladies that are athletic will often, and then we just say, check with you all to see what exercises to do. Recommend.
Yeah. For SPD. Use that, yeah. I've had at least a different chiropractor, one chiropractor I saw during my first pregnancy, do that, like inside and outside with your, like have somebody hold inside your knees and push, and outside your knees and push out to help.
It does. It's wonderful.
Yeah.
Or we just say at home, if we give them the exercise and need a chest resistance, get either one of those kids' balls, and we have one up there, or a full roll of paper towel, or a toilet paper.
Yes.
Or reach. You know, I can reach. I got long arms for a short person, so I can reach.
Right, and do that part, So that's a nice.
So since we're talking about the pelvis, what about the coccyx? Sometimes after baby has come through, the coccyx is kind of out of place. Yes. So is that able to be readjusted?
Yeah, we use. I use the single tip typically for that, or the sponge. We gotta get the sponge tip. This is a little bigger real estate, and it's a little bit more, and it's softer. So we have ways, even with the instrument, of adjusting, not intended, the area. I palpate it. You can't feel a whole lot, but sometimes you can feel that there's a greater space on one side of it because it's tapered, as you all know, it's tapered, kind of like arrowhead shape. And if there's more space on one side, we will tap it over to that side, just tapping it over. Also, I can use and have recently used a drop. I will put my thumb on the coccyx. This will kind of make a good coccyx right here. And cock this up. And then my line of drive would be typically towards the head. And what I tell people is when we're born, it's separate segments, but it's fused in childhood. Same with the sacrum. It's separate, and then there can be some congenital anomalies, but that tailbone can curl under, as you all know. I've seen it 90 degrees on x-ray.
Oh my goodness.
How do they do that?
Yeah.
You hope they're overweight, because they wouldn't feel it.
Right.
But I go on, is this going to show okay, Kameah?
I think so, yeah.
Yes. I put my thumb here, and then I'm pushing this way here at the junction, and then that can help it pop back
out.
But there is an internal adjustment, which I did learn at school and had to use on a young man. It's the only thing that relieved his piriformis. So it's kind of like a rectal. You put a finger cutter glove on, and you go in, and you just snag it and pull it back. It's real quick, fairly comfortable, I guess. Never had it done.
I have had it done. My husband actually helped me after I had my daughter with that exact maneuver. He's not medical at all, but I told him what to go in and do because I could just feel it in my body.
There you go.
Yeah.
Wonderful.
It was.
Well, I've never talked to anybody.
It was amazing. So much pain relief.
Yeah.
It seems like that would be worth it.
Yeah. It definitely is.
Especially, with your husband or someone you know.
Yes. One big thing that we are really concerned with as our moms get closer to their due date is the position of the baby. Obviously, an anterior on the left side baby or right is what we really look for, but sometimes babies are posterior and or breech. And so is there anything that chiropractic can do to help with position of
Yes.
baby.
This is probably my favorite application
Okay.
for chiropractic. I mean, we're always hopeful we don't need it for that. My mentor in the Webster technique said that if the baby should turn, it will. If it shouldn't, it won't.
Mm-hmm.
So that gives me a lot of peace.
Yes.
And the Webster technique, which we'll talk about in a second, but just getting the pelvis balanced, like you were talking about earlier, is probably all you need.
Yeah.
Because as you can see, this space here, you all live and breathe that, but the space here needs to be there proper so the baby can get out. So if you have those hip bones, instead of like this, they get rotated and they get like this, baby can't get out. Right. So when we adjust just the pelvis in whatever way, with the instrument, with the blocks, here we go, let's do that. We'll put one here and then one will go on the other side. Just to get that to open back up may be it. But the main culprit is usually the sacrum, the bone in the middle. And it's a beautiful bone. It's shaped like a comma, but that can move. It can move to the sides. It can tip forward. It can tip back. It can torsion. And that's my favorite bone to work on in the pelvis because I know what it's going to do. What we do on every pregnant woman, regardless, is we check for this. And we do it by using the Webster and then another one that I use on everybody. So if the Webster is clear, which is bringing the heels or the patients on their stomach, we bring the heels up. And if there's a difference in give, we know the sacrum's out. So we adjust the sacrum, the ilia if they need it, which they usually do. And then we flip them over and do a little soft tissue work, trigger point work on the round ligament.
Oh, perfect.
Which is usually the other side of whichever side the sacrum's out. Now, I have seen Webster being negative, but the test we use, which is the leg lift test, to be positive. So we fix it too. Yeah, but we don't need to do the round ligament with that one. So, well, one of my favorite deer in the headlight looks, you know, if you tell people you just, kids even, or babies, they're like, why? Is their back out? Or, you know, they don't understand. They don't understand. And you all correct me if I'm off, but I understand normal delivery is 70 to 120 pounds of pressure on the neck.
Okay.
That's in my training.
Okay.
Whatever it is, it's a lot. Yeah. It's a lot. But we want that because of all the wonderful things that happen. A little aside, learned at one of my foot training, we fit custom orthotics, and one of the teachers, who's also chiropractic pediatrician, said the last thing the baby does is push off on the pubic bone. Is that right? Oh yeah. Okay. Well, that starts the arches to form. So C-section babies, they're beautiful. Yeah. You know, my son was an inch shorter day 2 because of the cone head.
Yeah, right.
but you know, so they're at a little disadvantage. And the feet are so important. So I, depending on the situation and everybody's mood and all, say, well, we only adjust babies with spines. You know, just to get through. Well, they've got a spine.
They still have a structure that can be thrown out of whack.
Can definitely. We think it's a possible factor in SIDS, colic, digestion. You know, all of anything. I was going to tell a story, but we'll skip that. It's cute, but it's all right. So people are then, their mind is going to that traditional, the popping. Yeah. We don't do that. And the mothers hold the baby. And I palpate very lightly. And it's the pressure you would do if you're just touching your eyeball. And that'll do it. or the pressure you would use to test a ripe tomato. So it's very light. Babies are, depending on the age, they don't know what you're doing. They're pretty easy. Tiny infants are easy. Toddlers are easy if they've kind of grown up with it, because you can explain. You can hand them a tip, but it's that in between, because they want to know what I'm doing. They keep looking, and I can't palpate their neck. So it is a little of an issue, but it's very, very light pressure. That's how it goes. So that I love doing it, but it can be hard. I'm going to tell you a story. Should I pause in case you want to? We had a little boy. He wasn't quite 12 months, and we had treated some of his family members. We hadn't treated him. He had fallen off his brother's shoulder, tall brother. The mother saw that he was crying. Well, he's a baby and he's crying, and she checked him and did stuff. He was not weight bearing the next day. He wasn't walking quite yet, but she knew something was off. Took him to a pediatrician who checked him out and said he was fine. And she wasn't satisfied. Then she remembered us, brought him in, and at that age, I mean, I'm praying. I had my receptionist praying, because I'm like, I can't palpate. He's doing this. You know? So I did what I thought was right, and she said by the time we got home, he was up and walking.
Oh my goodness!
Wow. The same day.
Goosebumps.
I know. Right? I know. So we do pray for our patients. You know, we want to do a good job, best job. But when they're wiggly at a year old, you can't explain it. But it worked well.
Good. Yeah. Good. And how young can you see somebody?
I would love to be in the delivery room.
Yeah.
But in Virginia, we're not in hospitals yet. The youngest was a week old. It was in this room. The mother brought him in. Okay. Yeah. So as soon as a mom can get them in, and we do, and we had talked about it in the questions, and all I'll say is, because we can't discuss price publicly, we're not supposed to, and we may change it, but we do have a special thing for newborns up to about 6 months. You know, we want to get them a good start. Yeah.
I was at a birth on Monday night, and the baby was everything went great, but the baby was fussing a lot. He latched really well, and the midwife mentioned maybe he needs an adjustment. And so it would have been great to have you there that day, just to be like, let's just check it out and make sure. So.
Well, just a little aside. I love what I do. Close to 31 years doing it, and it was like my third career, so you know, I'm no spring chicken. But I get tired of being inside.
Yes.
Yeah. And I do some mission work, and I love that, because you're outside and, you know, different dynamics. But I visit established patients in nursing homes, you know, if they're there for whatever, hospitals. Yeah. I always have my hands with me, so I can kind of see. That's right. You know?
Yeah, that's the beauty of both of our lines of work.
That's right.
Our hands are always with us. These are the tools we need.
That's right. Yeah.
We're in Fishersville. We have a very nice office that's convenient. Like I said, I've been doing it almost 31 years. And I think the strength for me, the way I think, is everybody gets an individual adjustment way. Yes. You know, a lot of, we call it, well, we're going to hybridize it today. And as people get better, they may need a different type of adjustment. So I don't do the same thing. I have been in offices of mentors that I love and adore. And I can't tell any difference. And I'm trained. Yeah. But I think that's our forte, or a forte. And we are general practice from newborns to elderly. Love what we do. Great. We're off on Thursdays. But other than that, always learning too. I've had a lot of patients say, one thing I like about coming here is you're always learning. Absolutely. Always, And we do have to have continuing ed credits. When I first was in practice, we didn't. It was like first year maybe, and we have to have 30 a year. So people know.
That's, we similar thing. Yeah.
Thank you so much for joining us today.
check back in for part 2, where we will be showing an actual adjustment done in pregnancy.